First, I'd like to welcome everyone to Winter Haven Health and Rehab. My name is Nicholas Pulaski, and I'm the Staff Development Coordinator. I look forward to meeting all of you soon. The information I will be going over is important for everyone working in the facility and in all departments to absorb. As such, it's going to be presented in introductory format for all departments. Those with clinical roles will have this information expanded upon in Day 2 and Day 3 of orientation. Dementia. Dementia is an all-encompassing term that describes a collection of symptoms such as loss of memory, judgment, language, and complex motor skills, and other intellectual and cognitive functions. This is caused by a permanent damage or death of the brain's neurons, also known as nerve cells. Dementia is always progressive, with chronic deterioration of function, and it is not a normal part of aging. This means that symptoms will always get worse and never get past the resident's baseline. There may be times where symptoms become temporarily worse, such as with infections, a transient ischemic attack, also known as a TIA, or a mini stroke, dehydration, new medications, and stressful situations. This may result in a temporarily worsening of symptoms that can be alleviated if the infection or TIA is resolved, dehydration corrected, medication is changed, or the stress is removed. While the increase in symptoms may be temporary, it may also cause the baseline symptoms to get worse. The progression of symptoms is with the worsening of the individual's baseline, and the resident will never improve beyond their baseline, creating a new plateau. Some of the changes that happen to the brain are treatable, and they're reversible, allowing the symptoms to return to baseline. Other changes are irreversible and result in a new baseline of worse symptoms. Those that are elderly and at risk for a stroke or a TIA are more prone to dementia. There are three main causes of dementia that we will deal with in long-term care. Alzheimer's disease, which is 60 to 80% of all dementias. Lewy body dementia, which is the second most common form of dementia. And vascular or multi-infarct dementia, which is often a result of a stroke or from a chronic TIA. It is important to remember that Alzheimer's dementia is a disease that attacks a person's brain, and the symptoms are not always within their control. In the picture on the screen, the left picture is showing a healthy brain, while the right side shows a brain that has been affected by Alzheimer's disease. The death of the neurons creates a loss of mass in the brain. Alzheimer's disease begins with mild memory loss. It leads to the loss of ability to communicate and respond to the person's environment. The person may not be able to communicate outwardly. Alzheimer's disease involves the part of the brain that controls your thoughts, your memory, and your language. Alzheimer's disease will affect a person's ability to perform their activities of daily living. This is not a normal part of aging, and as the damage progresses, the complications that result from the damage may prove fatal. It is not the disease itself that kills the person, it's the symptoms. For example, the person may not respond to their environment and be unaware of the dangers or unable to assess the risk properly. They may forget to take their medications or to eat and drink, causing a failure to thrive. Dementia with Lewy bodies, the second most common form of dementia. A Lewy body dementia is the result of Lewy bodies forming in the individual's neurons. Lewy body is an abnormal protein formation. This type of dementia differs from Alzheimer's in that the speed of the brain functions is affected more so than the memory. These residents will have trouble finding the right word. They'll be slow to respond. They'll have more Parkinson-like symptoms such as tremors and loss of motor skills. An example of this would be the grip of a pencil. Someone with fine motor skills will grip a pencil with their fingers, while someone who is losing their fine motor skills will grip their pencil with a fist. The only way to conclusively diagnose Lewy body dementia is through an autopsy. Unfortunately, there is no test that will tell us that they have Lewy body dementia while they're alive. Providers will use a clinical diagnosis, which represents the provider's expert knowledge in diagnosing based upon the presenting symptoms of the individual. The third, vascular dementia or multi-infarct dementia. This is a form of dementia that is caused by a blockage of blood vessels. Acute symptoms, they may be reversed if the blockage can be relieved, but it also may cause a worsening of baseline symptoms. Those who are at risk for a stroke are at a higher risk for vascular dementia. When somebody has a TIA or a stroke, there's usually a blockage in the brain that's preventing the brain from getting oxygen. When that happens enough, it can trigger the dementia symptoms and cause the death of those neurons. It can be, if it's relieved quick enough, it may come back to baseline, but will never get better than baseline. If it doesn't get better and some of those neurons die, it can contribute to those symptoms worsening over time. Now, there are some warning signs of dementia. The individual may have memory problems, and it's typically the first warning sign of cognitive loss. It's not going to be the one that we think of in the media. It's usually, oh, I forgot my keys. That's a sign of dementia. That's not really the case here. There's more to it than just that. It's memory loss that disrupts daily life, such as getting lost in a familiar setting. Or it could be repeating questions. The person may have trouble handling money or paying bills. Your father that normally would pay bills on time, never missed one, always had a system in place. Now, all of a sudden, the family's going to notice that they're going to get late notices in the mail, and he's not going to know why. These are typically seen by friends, family, and the people closest to the individual. They may have difficulty completing familiar tasks, such as hobbies. It could be somebody that picked up crocheting all their life and they were crocheting the entire time. All of a sudden, they suddenly lose the ability to crochet. It can be somebody that was a crafter and all of a sudden they have no interest in crafting anymore. It could be decreased or poor judgment. This contributes to them being unaware of the risks they are taking. They may misplace things and being unable to retrace their steps to find them. This goes in, it's not just forgetting your keys. It's forgetting your keys and not being able to retrace where you were for the past 2 hours. As the disease progresses, you're going to have changes in mood, personality, behavioral changes. It often starts with anger and being defensive to cover the difficulties and progresses to significant changes as the disease progresses further. The grandmother that would reprimand her family for using foul language and dress very conservatively may now be cursing at every chance she gets and maybe stripping off her clothes, having no inhibitions whatsoever. How is Alzheimer's treated? Unfortunately, there's only one medication that treats Alzheimer's directly. All other treatments focuses on alleviating the symptoms. The one treatment, it's called aducanumab. It helps slow the progression of the disease, but it will not cure it, or it will not take the symptoms away. It could be, we're going to use those medications to focus on the complications of the disease. So for example, using a sleep aid to treat insomnia, an anti-anxiety medication to treat the increases in anxiety or agitation, an appetite stimulant if they are not eating well, among many other options. There are also non-pharmacological treatments. It's also very extremely important to use those non-pharmacological treatments, since stimulating the brain aids in slowing the progress of the disease, engaging residents in conversation, even if they cannot respond, engaging them in activities, puzzles, among many other options of activities, get them to use their brains and slows that progression down. Managing behavioral symptoms decreases the use of medications and decreases the risk associated with the outbursts that may lead to a decrease in caregiver role strain, slowing the progression of disease, and ultimately we're going to give a better quality of life for that resident. So how do we relate to those persons with Alzheimer's dementia? One, we cannot force a resident to accept the real world. It's just not in them. What they are seeing, what they are feeling, what they are observing is real to them at the moment, even if it is not based in reality. They can be present at one moment, maybe they were a child at another, it could be that they're in the future at the next. Time has no continuity. We don't want to argue with a person that has dementia. Not only is it a no-win situation, you could be banging your head against a brick wall and you'll have a better chance of getting through to them. But what they see, what they feel, what they believe is very real to them and will only put them in a defensive mode. We must guide the resident and steer their behavior to something that is less harmful and less detrimental. The more we can guide them away from those harmful and problematic behaviors, the better their quality of life will be. A good example here is a person with dementia is asking to go home because he thinks he left the front door open. You know, as a caregiver, this information is not true. They were here for the last 3 years. Their family doesn't visit. Your response? Well, you're going to tell them that, well, I'll call your niece. It's okay. Well, I'll make sure she shuts the front door. Pretend to call that niece, and then if the dementia patient still insists on going home, tell them, you know what, we'll go. I'll take you home, but we have to set dinner. We have to have dinner before we go. Or anything else that you know that resident will want to do. The trick to this is to nip that agitated behavior in the bud before it becomes a problem, before it reaches that catastrophic reaction, before that resident gets too upset and then no longer can be calmed down. This will help increase their quality of life, increase your satisfaction because you'll be less annoyed. Now, if I said, what is a catastrophic reaction? Not everybody knows what a catastrophic reaction is. But it is a type of behavior that is seen with somebody that has dementia. A catastrophic reaction is just an emotional reaction to something that's trivial. It could be, you know what? I wanted to have peas instead of carrots, and now I'm going to throw this chair because I didn't get my way. Almost like a child's tantrum. These reactions are one of the single greatest challenges the caregivers of those with dementia will react to. It requires that you have a unique set of skills and knowledge to be able to deal with these situations. Behaviors in these people with dementia, they're associated with a decrease in quality of life, distress of caregivers, misuse of medications, increased costs. Not only will it decrease the quality of life of those with dementia, if we can't deal with these effectively, it leads to burnout of the caregivers. It leads to misuse of medications. They're going to have a lot more medications if we can't deal with the behaviors without pharmacological methods. It leads to increased costs for everybody. It takes away from the care you give to other residents as well. The next section that we will be covering is HIV and AIDS. I'm sure everybody has heard the term AIDS somewhere before, whether it be in media and home use or just somewhere you've heard the term AIDS. But do you know the difference between HIV and AIDS? HIV is known as the human immunodeficiency virus, while AIDS is the acquired immune deficiency syndrome. AIDS is a late-stage infection of HIV. A person that has HIV may be asymptomatic for many years, even decades, before their immune system is depleted enough to develop into AIDS. Asymptomatic, it just means that they don't have any presenting symptoms and you're unable to tell that they're even sick. HIV attacks the body's CD4 cells. CD4 cells are just white blood cells that are important for your immune system function. When your CD4 cells count drops below 200, you become extremely susceptible to infection. A diagnosis of AIDS occurs when that CD4 count drops below 200 and you develop an AIDS-defining infection. It's just an infection that your body would have otherwise fought off. One of the most common infections is pneumocystis carinii. The only way you can get it is if you have your immune system is not functioning properly. You have this bacteria in your system already, and as HIV attacks your immune system and it decreases, the bacteria pneumocystis carinii can overtake and become opportunistic and then infect you and cause a problem. Even though much is known about AIDS now, there are still many myths that float around that make it more problematic to deal with. The main myths: you can't catch AIDS from toilet seats. You're not going to get it from shaking hands, and you're not going to get it from food preparation. The only proven method of transmission happens through unprotected sex exposure to blood and blood products, and from mother to child during childbirth. We limit transmission through behavior modification, safe sex practices, monogamous relationships, and no sharing of needles. One of the main ways we limit transmission is through universal precautions. And we'll get more into that in the next section. The next large section that we're going to be covering is infection prevention and control. So the first thing we're going to cover is the chain of infection. The chain of infection is the best modeled representation of the spread of infection and can be separated into 6 links. The infectious agent, right up top in red. The reservoir, purple, pinkish. The portal of exit, orange on the right. Modes of transmission, in blue on the bottom. The portal of entry, in yellow, and the susceptible host up on the left. If we can break any one of these links, in the chain of infection, then we can prevent infection from spreading. So let's start with explaining what each link entails. The infectious agents. The infectious agents are just any microorganism that is capable of causing disease in humans, or in other words, any pathogen. This can be a bacteria, a fungi, parasite, a prion, a virus, any of those infectious agents. The next step of that is that it needs a place to grow, to reproduce, or replicate itself. This is called a reservoir. This is where it lives, where it grows, where it reproduces itself. It can be any standing body of water. It can be undercooked food, or it can be the person where that infection is growing. From that reservoir, the pathogen needs a way out. Bacteria in standing bodies of water, undercooked food can easily exit the reservoir, while exiting a human body is done in a few different ways. This may be through exposed blood, secretions, excretions, a break in the skin, mucous membranes, among many other options. From that exit, that infected person, that bacteria needs a way to be transmitted to the next person, that uninfected person. A mode of transmission is how the pathogen gets from the exit of an infected person to the entry of an unaffected person. This may be through physical contact, either through direct contact, just like measles and mumps, you need direct contact with somebody, or through indirect contact by touching the same objects. It can be through water droplets that is usually spread by coughing. Usually an upper respiratory infection such as influenza and COVID are the ones we have to worry about with droplet precautions. Or it can be through pathogens that are suspended in the air. The bacteria itself is so light that the movement of air keeps it suspended. Almost like if you see smoke after a fireworks show, how it's just suspended in midair. That's what the bacteria is doing when it's an airborne transmission. This is an example of this would be tuberculosis. From that transmission, we have to have a way into the body. This is going to be your portal of entry. This is how that pathogen enters the non-infected person. It can be through mucous membranes, a respiratory system by breathing the pathogen in, digestive system by ingesting the pathogen through a break in the skin. This breaks in the skin can be through surgical incisions. It can be through pressure ulcers, other wounds, skin tears. It can be through abrasions. It can be through a puncture. It can be through mucous membranes. So your mouth is a mucous membrane. Your eyes are mucous membranes. It's one of the main reasons why people recommend when we're dealing with COVID that we wear those face shields, because you can still catch it through the mucous membranes in your eyes. Once that bacteria enters your body, you have to be susceptible to that bacteria to be infected. And it's what determines how likely you are to be infected. Those at higher risk are those who generally they don't eat a healthy diet. They could be recovering from surgery. They could have a significant burn or a significant wound. It could be extreme age. The very young and the very old are at a higher risk. Or it can be a disease process, such as diabetes, that causes them to be a more susceptible host to that bacteria. It can also be less susceptible to some infections. You can be eating a healthy diet. You can be exercising daily. You can become vaccinated or have already come in contact with the disease once. This is very demonstrable with chickenpox. Once you catch chickenpox, you're not going to get chickenpox again. And with a lot of diseases, after you catch them the first time, you're less likely to catch them a second time. Not always, but it is the case with most. There are some potentially infectious agents that we have to worry about in long-term care, specifically a few that I want to highlight. Some of the most common noteworthy infectious agents that you're going to be exposed to in a long-term care setting are bloodborne pathogens. This is any pathogen that is spread through contact with blood or blood products. It can be viral hepatitis. Another one is Mycobacterium tuberculosis or TB. Another one is an MDRO and Clostridium difficile. A question that may be going through your mind, especially if you haven't dealt with the clinical operations side of long-term care, is what do those letters stand for? An MDRO, they're just pathogens that have become resistant to certain medications. MDRO just stands for multi-drug resistant organisms. VRE and MRSA are types of MDROs that are common in healthcare. They stand for vancomycin resistant enterococcus, and for MRSA, methicillin resistant Staphylococcus aureus. Clostridium difficile, also known as C. diff, may also be considered an MDRO in certain cases. There are a few different types of precautions that we use. Standard or universal precautions, that is what came about as a result of the AIDS epidemic, late 80s, early 90s, where we had to figure out how to deal with this new infection that came out. And what was thought was, we are going to treat everybody as potentially infectious. So we're going to take precautions assuming everyone is potentially infected. With standard and universal precautions, we use personal protective equipment, or PPE, regardless of the diagnosis. We use that PPE for what we expect to encounter when we're caring for that resident. All body fluids are considered potentially infectious. If we're going in there to care for them, to give them a bed bath, well, we may get something on our clothes, we may get something on our hands, so we're going to wear gowns and gloves. If we're worried about somebody coughing on us, we're going to wear a mask, or we're going to wear a mask and face shield. It all depends on what we expect to encounter. Somebody that is on contact for C. diff, if you're just going in there to talk with them, it's likely that you may not need to gown up because it's not spread through the air. It's spread through contact. There are 3 categories of transmission-based precautions, which are specific to certain disease types. For contact precaution, we're going to use them to prevent transmission of a pathogen that is spread by direct or indirect contact. An example of this could be through skin-to-skin contact with measles or mumps, or using the same object as someone who has conjunctivitis or pink eye. If we're using the same objects and we touch our eyes, we can catch pink eye. A subset of these infections is with C. diff infections. C. diff requires that soap and water be used upon entering and exiting the resident's room. This is because C. diff is spread by spores in which alcohol cannot kill the spores. It's actually very resistant to alcohol. So in order to get it, we have to use soap and water to get it off of our hands. The next one that we're going to talk about is droplet precautions. This one is all the rage now with COVID. It's used to prevent transmission of pathogens spread within respiratory droplets over short distances. An example of this is the flu virus or influenza. These type of pathogens are usually respiratory in nature, meaning that they infect the respiratory system. Another one is airborne precautions. These are used to prevent transmission of pathogens contained in particles that remain suspended in the air over time and over a large distance. These patients require a negative air pressure room, which is only available at the hospital. Not only if somebody tests positive, we're going to send them to the hospital, but also we're not going to accept anybody in with an active disease that requires airborne precautions. To help prevent the spread of infection, hand hygiene is bar none the best way to prevent the spread of infection. Hand hygiene is just a term that means washing your hands with soap and water or using alcohol-based hand sanitizer. In general, hand hygiene is always going to be the best way to prevent a spread of infection. There are a few situations in which you don't want to use that alcohol-based hand sanitizer. The first is going to be with infections like C. diff, where the pathogen is resistant to disinfection by alcohol. It can be when your hands are visibly soiled, or when your hands become tacky after using sanitizer too much, then you must use soap and water to clean your hands. Especially when using the foam sanitizer, it tends to leave a sticky film over your hands, and your hands aren't really going to be clean after that. To wash your hands, you first want to wet your hands with water and apply soap, usually 3 to 5 milliliters. That's how much soap comes out with one squeeze of the bottle. You're going to rub your hands together vigorously, making sure you get the back of your hands between your fingers and in the tips of your fingers and your nails by rubbing the tips of those fingers in the palm of your opposite hand. You're going to rinse your hands with water and use a disposable towel to dry your hands and then turn off the faucet. You don't want to use extremely hot water to wash your hands. When you do use extremely hot water, it dries out your skin faster, which not only does it cause excessive drying, but you'll also end up with cracks and fissures in your hand as a result of doing that too often. There are some reportable conditions that the employee would have to notify of. And if you do experience any of these following conditions, report it to your supervisor or the director of nursing. The first one is going to be a severe acute diarrhea illness with other symptoms such as fever, abdominal cramping, bleeding that lasts longer than 24 hours. It could be orofacial herpes outbreak or herpes infection of the fingers. It could be infected skin lesions of the extremities. We need to know about this because if there is an outbreak, especially in your extremities or in places where the resident may be exposed, we could have an outbreak. It could be diagnosed group A sore throat, diagnosed strep group A sore throat. It could be an acute upper respiratory infection of influenza, and now as COVID as well. It can be any diagnosed condition that is usually vaccinated against as a child, which could include measles, mumps, rubella. It could be the varicella zoster, which is just another name for chickenpox or shingles, and tuberculosis. It could be any highly contagious illness such as conjunctivitis, also known as pink eye, lice, or scabies. With all of these conditions, there is a lot that goes into it to prevent the spread, and a lot of times if somebody comes in contact with our residents, we have to act proactively and treat with prevention measures. Another thing that is reportable is a needle stick, a sharps accident, or exposure to resident blood or body fluids containing visible blood with a mucous membrane or non-intact skin. These we want to be reported to the immediate supervisor so we can take the proper steps and reduce any potential adverse reactions as a result of this exposure. Following on this infection prevention theme we're going to talk about bloodborne pathogens. So what is a bloodborne pathogen? It can be HIV, human immunodeficiency virus. It could be the hepatitis B virus. It could be the hepatitis C virus. It is just any pathogen that is spread through contact with blood and blood products. So how may you be exposed? How are they spread at work? Bloodborne pathogens, they are spread through exposure to blood or body fluids containing visible blood. It can be through non-intact skin. It could be any break in the skin, an abrasion, a cut, a surgical incision, any type of break in the skin. It can be through mucous membrane contact or through a needle stick injury. If an exposure occurs, notify the supervisor immediately. This allows us to follow the proper process, and it also helps protect your safety. We want to become familiar with the spill kit. Where is it located? How to use it. It is located on each nurse's station, and there are extra spill kits in the small central supply room. The body fluids that could contain bloodborne pathogens include blood, body fluids containing visible blood, Body fluids that cover internal body organs. Vaginal secretions. Semen. Saliva in the dental setting, often because there's a chance of blood being in the saliva in the dental setting. And breast milk. So how can we protect ourselves from bloodborne pathogens? Well, we're going to use personal protective equipment, or PPE. The selection of personal protective equipment is based upon the type of conditions and the degree of potential exposure that is expected. Hand hygiene is also important as it helps prevent the spread of infection to other residents and to yourself. How we don't want to handle sharps. Never recap, never bend, never break, never manipulate sharps following use. Never carry sharps in your pocket. Never transport sharps without the safety feature engaged, and never place your hand in the sharps container. Most needle stick injuries occur after the use, but before they are properly disposed of, and attempting to manipulate the sharps in the sharps container. Biomedical waste. Biomedical waste is any solid, liquid waste that it presents a threat of infection to humans. This is our red bag waste. Biomedical waste can be transmitted by sharps, absorbent materials such as bandages, sponges, soiled gauze, and non-absorbent materials such as hard surfaces and plastics. Biomedical waste gets put into a red disposal bag that is collected in each of the soiled utility rooms where there is a dedicated bin for red bag collection. Sharps containers are considered biohazard waste when closed. Outside of the facility, the biohazard waste is collected in a locked and labeled dumpster until it is collected. Sharps containers are located on each of the medication carts, with replacement bins in central supply. The med cart keys contain the key for the Sharps container lock. Once a Sharps container is 3/4 of the way full, it must be closed, discarded, and replaced. This line is often represented by a change in color. Often represented by a change in color on the label of the Sharps container, or there is a raised plastic marking on the container itself. In all cases, the 3/4 fill line will be clearly identifiable. When dealing with sharps, never leave a sharp or a needle on a bed. Never dispose of sharps in regular trash. Exercise care when handling sharps. And think about the safety of yourself, your residents, and your coworkers. We don't want to do anything that puts any of their safety at a higher risk. As part of our infection prevention program, we offer 3 vaccinations, not just the 2 that are listed here, free of charge to all employees. These are the Hepatitis B vaccine series, the seasonal influenza vaccine, and the COVID vaccine. The facility will not accept any resident with active tuberculosis. This is because we cannot care for airborne precautions. We do not have the capability to do so at the facility. Employees will be screened for tuberculosis upon hire and annually each year. There is no annual PPD. Screening questions are used instead. A negative chest X-ray within the last 12 months will be required for all workers or volunteers with a known positive PPD or allergy to PPD, and is good for up to 5 years from the date of the test. Persons with a suspected active TB will be referred to their provider for further evaluation, and those with latent TB will require testing and possible treatment. TB is spread through microscopic droplets that contain bacteria. Transmission may occur when an infected person sneezes, when they cough, or if they speak, which releases the bacteria from their lungs into the air. The bacteria may live outside the body for several hours. Persons with an active tuberculosis must be transferred to an appropriate setting for treatment. Airborne precautions are required. You are required to report any known exposure to tuberculosis, to cooperate with the facility screening policy, and attend any annual TB education sessions, which are usually done by me. The next one is with the influenza vaccine. Influenza represents a major source of morbidity and mortality to residents of long-term care facilities, and the use of the influenza vaccine drastically reduces the risk for our residents at preventing illness, hospitalization, and death. The influenza vaccine is provided to all staff at no charge. All residents, regardless of age and medical condition, will be offered the influenza vaccine. The facility will continue to offer the vaccine to unvaccinated persons and newly admitted residents all throughout the influenza season, which runs from October 1st through March 31st. The facility offers the Hepatitis B vaccine series to employees who have the potential for occupational exposure at no cost to the employee. If you have a potential exposure to Hepatitis B, you will be offered the Hepatitis B vaccination after the exposure or the potential exposure to prevent any adverse effects. The next section we will talk about is COVID-19. COVID-19 is a virus that may cause cold and flu-like symptoms, ranging from mild to severe, and it may be fatal in some cases. Symptoms include, but they are not limited to, the following in separate or in combination: elevated temperature over 100 degrees, a fever with or without chills, recent onset of cough, shortness of breath, difficulty breathing, a recent onset of fatigue, muscle aches, body aches, headaches, sore throat, congestion, runny nose, a new loss of taste or smell, nausea, diarrhea, and vomiting. What we can do to take precautions, we want to prevent anything from happening first. That is the best method at stopping the spread of infection. Prevention includes frequently washing your hands, using alcohol-based hand sanitizer, wearing a mask and appropriate PPE at work, and taking reasonable precautions outside of work. It is everyone's responsibility to work and live safely during a pandemic. This allows us to provide a safe environment for our residents. Residents and staff must follow the governmental and regulatory requirements for testing. If a resident does not follow testing requirements, it may prevent admission to the facility. If an employee does not follow the testing procedure, it will result in being unable to work and a possible disciplinary action. If you cannot make a scheduled testing or cannot provide a negative test during that time, you must contact clinical management prior to the testing date to discuss your options. And let me emphasize that you have to contact prior to the testing date so that we may tell you about the options that we can do. Screening must be followed by all staff, all visitors, all vendors prior to entering the facility. Nobody is allowed to enter the facility without being screened first. PPE is required for all units at varying levels throughout the building. If you are unsure of the requirements for a specific resident, ask the nurse that's caring for that resident or a supervisor for guidance. COVID testing requirements, they change frequently. It's based upon the Department of Health and CDC guidelines. It also follows the county transmission rate in Polk County. Employees will be notified when the requirements change. Failure to test or to provide a valid negative test during that time frame will result in the inability to work. If you don't test during that week, it's likely that you're going to be unable to work unless you test yourself and bring that in prior to working. And it's likely if you do have to miss time as a result of not testing, there will be some disciplinary action that follows if it's not communicated to the clinical team prior to missing the test. Thank you very much.